And without further ado, introduce Jessica, who's going to be talking to us about substance abuse support services and addiction services. So thanks for joining us, Jess.
Great. Thank you so much, Jen. I appreciate it. And thank you everybody for joining. As Jen said, my name is Jess Sorbello. I am the project director for Project COPE. And that is a grant that is being run through Oasis, which is focusing on overdose prevention strategies throughout New York State with a specific focus on those who are not currently receiving substance use treatment. So really looking at kind of targeting some of the various groups that experience a significant amount of barriers and additional factors to kind of preventing them from either asking for help or for accessing care in a really kind of easily maintainable way. So I am going to kind of jump right into a PowerPoint. And I will say this is actually the first professional training that we are doing. As Jen said, I will be sending out the evaluation following this, and I would ask for kind of some of that honest feedback in able to, kind of continue to evolve the trainings as we go to, if there's things that folks wish that they had heard, wish that they had understood, learn more about, I definitely would love all of that information so that kind of over the next few trainings, we can really get things moving and be able to, really kind of formulate this to really best, speak to kind of what everybody is looking for. Just a little background on the grant before we jump into the slide deck. And as I said, we are focusing on individuals not involved in treatment programs and specifically really looking at pregnant parenting postpartum persons, survivors of domestic and intimate partner violence, members of the LGBTQ+ community, and members of the tribal community. And now I know that a majority of folks on this call are with the home visiting child welfare side of things. And so a big part of what we're doing with these trainings is looking to help to establish a universal kind of understanding and approach to overdose prevention and substance use. Prior to my role overseeing this grant, I've been in the clinical realm, and I'm sure like many of you have really kind of experienced the siloed system that still exists. We focus on substance use, you focus on child welfare, other agencies focus on medical or mental health. And while things have certainly improved, there does seem to still be that kind of, again, just barriers between the systems. As I've seen over the years, I'm pretty sure I've never met one client who has only one issue going on, right? Where they only need help from one specific system. Most of our clients, require those services from multiple agencies, and it can be really difficult to connect those dots and, to kind of, assess, what needs to happen first, what needs to happen second, and then kind of just how to, again, connect everything to be able to give that best care. And we know that rates of overdose are continuing to rise. We'll talk specifics, with the training, but as I'm sure many of you have heard within the news, in 2020, nationally, it was over 100,000 deaths from opioid overdose. And we know that even though there are so many programs, there are so many things happening to try to get the knowledge out there, folks are still dying. And, one of the things that we're really focusing on with this grant is recognizing how many missed opportunities there might be for our clients to be able to get some of that information and get those resources. So I do want to kind of just say that as a little bit of a preface. This training is by no means expecting any one of you to be substance use treatment providers. That is not the goal of this. This is purely to provide the information and hopefully take some of the fear and discomfort out of talking about the basics of substance use and overdose prevention, and recognizing that overdose prevention is really just another type of medical intervention, in which we provide information, we provide the resources, and as much as anyone and everyone is at risk for overdose, anyone and everyone is also able to provide the information and be able to assess for that risk and get some of these overdose prevention kits and education, out into the community. And hopefully we can continue to see some of these rates, decrease as more and more individuals have access to all of these kits and information. So, yeah. All right. Sorry, give me 1 second. I'm on a different computer, so trying to get it onto the correct screen. All right, everyone. Okay, let's try that again. Okay, can everybody see the PowerPoint? Perfect. Okay. All right, so as I said, I am with Project COPE, which stands for Community Overdose and Prevention Education. So really looking at combining, the education, helping to empower professionals in all areas of the human service field to be able to recognize warning signs, intervene in an overdose, but also really be able to have the conversation, and find out, what resources are available and how to connect our clients. So what to expect from this training, looking at, being able to better understand substance use and the prevalence of use and misuse, how to discuss substance use and overdose prevention while using anti-stigmatizing language, the barriers that prevent those at risk of overdose from accessing services or requesting resources, and then how to recognize and intervene within an overdose. So this material is funded by SAMHSA as part of our grant. Okay. So as I said, this is largely looking at providing the basic information and being able to understand exactly what it is, we are looking for and how to talk about it in a comfortable way. So opioids, natural synthetic or semi-synthetic substances that interact with opioid receptors in the body, including the brain, and reduce the intensity of all pain signals and feelings of all types of pain. And that includes physical, emotional, and psychological pain. Examples of opioids include heroin, fentanyl, and all other analogs, both prescribed and non-prescribed. And something to just keep in mind is that just because somebody is providing a medication that, right, and then we have stimulants. So substances that temporarily increase stimulation of one's brain and central nervous system. And some examples of this include speed, cocaine, ecstasy, Molly, and methamphetamine. These are particularly important to understand in this training because for so long, the narrative was really, just about opioid overdose, which again, we know that the opioids are in fact what are causing the overdoses. But it's no longer primarily occurring as a result of somebody who is necessarily intentionally using opioids. Many stimulants, and again, those pre-pressed pills are being cut with fentanyl, and that is actually a large amount of what is causing the increase in the overdoses, because while fentanyl is incredibly deadly for anybody, regardless of their tolerance of opiates, somebody who's using stimulants very possibly has no opioid tolerance at all. And so again, somebody who's intending to use cocaine has no ability in their body to be able to process any amount of opioids. And so that very, very small amount of fentanyl is going to cause an overdose. And for many, they are individuals who in the past weren't educated on naloxone and didn't necessarily have some of these life-saving tools at hand. So common opioids, we've got heroin, fentanyl, and prescribed opioids. So as we've kind of talked about, prescribed opioids, again, oxycodone, hydrocodone, morphine, those are the medications that you're going to be prescribed from a provider, from a doctor following a surgery, and likely may even have in your medicine cabinet right now. Fentanyl is a highly potent, fast-acting synthetic opioid, and this is what's being cut and laced with so many substances throughout the country, and is really the leading cause of the opioid epidemic. So these illicitly manufactured fentanyl is the main driver of recent increases in opioid deaths. Got ahead of myself there. It's distributed through illegal markets for its heroin-like effect. And it's often added to other substances such as heroin, crack, cocaine, counterfeit pills, ketamine, and methamphetamine. And something that I think is important to kind of mention, I think especially for those of you who don't primarily work within the substance use field, for a long time, there was a lot of energy and effort going into making sure that the news and media sources were alerting folks to these spikes in overdoses, and kind of where they were happening in the attempt to deter folks from wanting to purchase substances to use in that area, not knowing necessarily where they're coming from. And for folks who really have significant substance use disorders, it's actually seen as a bit of a challenge, and it can really increase the likelihood of somebody wanting to go and purchase and use in those areas in the attempt to obtain the substance that has killed folks, because again, it does, there's that kind of belief that everybody is stronger than somebody else. So it's really important to kind of hear and understand that alerting everybody to where the overdoses are happening is not necessarily a helpful step. And I think that it's also important to understand where many clients are coming from, is that, just because things may not make sense to us, right, and they don't necessarily appear rational, many of our clients are not necessarily thinking and making decisions in that most rational way. So there is an appeal of, being stronger than the fentanyl. Substances containing fentanyl are similarly high potent opioids, even in very small amounts, increase the risk of overdose. So 3 milligrams of fentanyl can be fatal compared to 30 milligrams of heroin. And again, that is specifically for somebody who does have at least a baseline opioid tolerance. So if we're looking at folks who are using stimulants, whether it's regularly or as occasional use, there is absolutely no tolerance built up within their system. There are multiple different options to obtain fentanyl test strips, and that is something that our program is really helping to connect home visiting staff and child welfare workers with, in order to be able to get these strips distributed to clients and to these high-risk families, because again, it's not just the folks who are presenting with years and years of heroin use disorders. It's the overdoses that are happening when somebody's using occasionally when they go out on the weekend, or for many, using for the first time in years, and that substance is cut with fentanyl and then they're dying. So we do want to really start to increase the knowledge and awareness of fentanyl test strips. Listed are some places that you can obtain them. And then, as I said, I do also have a large amount here with me through the grant that I would love to be able to distribute to some of the agencies so that we can help to increase some of the access to those strips. So how opioids work. They bind to and activate specific receptors in the body, including the brain, brainstem, and spinal cord. Different opioids have a different affinity for the opioid receptors and activate the receptors differently. When they are activated, pain signals sent to the rest of the body are blocked, dopamine is released, and the body's wakefulness, breathing, digestion, and blood pressure are suppressed, which we will talk a bit more, but ultimately that is what an overdose is that that suppression of the respiration system is so significant that the individual is no longer able to breathe effectively. So I'm hoping, so on my screen, I see Maggie and Jen O'Connor. If you could just let me know if you can hear this in a moment, because I'm not sure with the back and forth if I checked the share sound.
We can't hear it.
Okay. Let me just stop and restart. Okay, let's try this again.
It's helpful to see how opioids work in the body. Opioids are agonists. This means they bind to and activate specific receptors in the body, including the brain, brainstem, and spinal cord. When these receptors are activated, people experience the effects produced by opioids, such as pain relief, euphoria, calmness, relaxation, and slowed breathing. Taking too many opioids causes so many receptors to fill and activate that breathing may become dangerously slow and even stop. This is how an opioid overdose happens, and this is where naloxone can help. Naloxone has a strong affinity to opioid receptors, more so than most prescription opioids and heroin. But unlike opioids, naloxone is an antagonist. This means it attaches to opioid receptors without activating them. So when naloxone is administered during an overdose, it knocks the opioids responsible out of the way and allows breathing to normalize. Naloxone can be administered through an injection or a nasal spray. It usually starts working within a few minutes and lasts from 30 to 90 minutes. While one dose of naloxone can reverse an overdose, sometimes multiple doses are needed, especially in cases involving extremely potent opioids like fentanyl, or opioids that stay in the body longer than naloxone. Naloxone is very safe in single or multiple doses. It may produce withdrawal symptoms in people with opioid dependence, but it has no abuse potential and cannot cause an overdose. It's important to remember that naloxone is opioid-specific. It has no effect on an overdose caused solely by non-opioid substances like benzodiazepines or alcohol. At the same time, people shouldn't be afraid to use naloxone when the cause of an overdose is unknown. If opioids were not involved in an overdose, it won't cause any harm. If opioids were involved, naloxone can save a life.
Okay, So that provides a basic overview of how opioids work and then how naloxone works and what the purpose is. And so I do want to talk a little bit, again, just kind of helping to, normalize addiction in really understanding what it is, and that it's not a behavior. It's not something that somebody is doing wrong. There's a lot of pieces that go into it, and ultimately somebody is continuing to use because that need is far higher than anything else. We know that we need dopamine to live, and the dopamine that is provided by a substance far outweighs any other form of dopamine that we have ever received. And so when we think to a period where you have been without caffeine, alcohol, another substance, but even food, water, human connection, right? I think we can all kind of reflect back to those periods of time during COVID where we had no human connection, and that need and that ache that we all felt, and that was real and that was strong. But again, that need for a substance, especially for somebody who is using frequently, again, is stronger than any of that. So there is that strong need to just function. And after a short period of time, it really stops being about getting high. It's just, again, being able to function enough to get through the day. So, I know that the video kind of spoke briefly to it, but really looking at, how an overdose occurs. And an overdose can be fatal or non-fatal. Somebody can have an overdose and, still survive even without the use of naloxone. The opioids gradually suppress the involuntary drive to breathe. So again, it's suppressing that respiratory system. Breathing slows down, and if it slows down too much, the heart stops. And it is rare for somebody to die immediately from an overdose. It can take time for the effects to reach a fatal level. But that being said, if you suspect that somebody is experiencing an overdose, don't wait. Naloxone is not going to harm anybody if they don't have opiates in their system. So you cannot use it too early. So risk factors for overdose, polysubstance use. So an illicit substance use, such as fentanyl or its analog, can be added to any substance. So again, that lack of tolerance is going to continue to increase somebody's risk. Changes in tolerance. So tolerance can change based on weight, size, illness, stress, and age. And especially important to recognize that somebody who has a period of time without using, they cannot just go back to using the same amount that they did in the past. A period of time without substance use, that tolerance is going to change. So especially when we're talking about individuals who have gone through a recent pregnancy and delivery, if they were able to maintain abstinence for that period of time, going back and beginning to use again with that same amount is incredibly deadly, because their weight has obviously changed, plus, all of their stress, their body function, all of those things. But their tolerance is not anything like what it was prior to, becoming pregnant or that period of time where they stopped using. So I would encourage everybody, as we're working on, being able to kind of normalize and, put ourselves in the shoes of many of our clients. Think back to a period of time where you may have noticed that change in tolerance. Again, caffeine, alcohol, other substances. But again, even just, sweets, salty food, right? All of those things that, we may have to work a little bit harder to maintain those healthier decisions around. And where all of a sudden, you went a period of time without, having candy, right? And what that feels like when you finally then have another piece. And for a couple of days, you're able to just kind of maintain that really healthy moderation. But, again, how quickly and easily it is to still kind of slide back to that place where we feel like we have less control. So risk reduction, do a test dose. So use a small amount before doing a full dose. Buy from people you trust and ask about the changes in the product. And again, that is a really a difficult line to kind of walk because, most dealers are not trustworthy. And so really kind of just helping our clients to understand that. And that again, just because somebody says that it is a Xanax or a hydrocodone, if they're not seeing it come from a pharmacy, there is no guarantee that there is nothing else laced within that pill. Tolerance can decrease rapidly when someone abstains from a substance or is not on medication for an opioid use disorder. Utilizing tools like the fentanyl test strips to test any and all substances. Use with someone else and take turns, so really kind of, focusing on the do not use alone. Do not use behind a locked door. And it's that idea of the safer that you are, the more likely you are going to survive. And that is ultimately what this training and all of these conversations are about, is decreasing that risk of somebody dying. So there is a hotline, Never Use Alone, where if somebody is using by themselves, they are able to call and somebody will stay on the line and talk with them. And again, it's completely, it's confidential in the sense that, nothing legally is going to happen to it, but there is obviously information on where the individual is and their phone number, so that if something happens and they stop being responsive, an ambulance or emergency services are able to be called. So fentanyl test strips. On August of 2017, in response to the increase in fentanyl in the drug supply, the DOPE project partnered with the Syringe Access Collaborative to pilot a fentanyl test strip monitoring survey. And 84% of respondents were concerned about the drugs that they use having fentanyl in them. The test strips allowed people who are using to be more informed about the substances they are buying and using, leading to behavior changes and the adoption of increased harm reduction measures, including sharing information among their peers. So again, the fentanyl test strips really help to normalize the conversation, and it takes a large amount of that stigma and judgment away, and recognizing it's important to just be informed and know exactly what is happening and what you are using. They're a useful engagement tool to foster discussions with people who use substances, and practicing universal precautions and anticipating the presence of fentanyl in their supply. So again, this is not just meant for those who are using heroin. It's likely in many ways probably more important to test stimulants and the other substances. So stigma. Stigma is a set of attitudes, beliefs, behaviors, and structures that can lead to a prejudice or discrimination against people with mental health diagnoses and substance use disorders, as well as other diagnoses such as HIV and HCV. So nearly 90% of people with substance use disorder do not receive treatment. In 2019, only 18% of people with opioid use disorder received medications to treat it. So please just take a moment to really look at the discrepancy in those numbers, especially when we look at how many people died in 2020. Over 100,000 people throughout the country died of an opiate overdose. And we see here that 90% of people with substance use disorders are not receiving treatment. And stigma plays a very, very large part in that discrepancy, especially among the pregnant, parenting, and postpartum persons, new parents, and again, many of the individuals that y'all are working with. And again, that stigma and that fear of judgment and repercussions are a big, big part of that. So stigma can make people feel like they're not deserving of being treated with dignity and respect. And if they feel like they don't deserve it, an individual is certainly not going to engage in behavior that promotes respecting of themselves. And that would include, testing their medications and getting overdose prevention measures in place. Because if they don't feel like they deserve dignity and respect, again, they're not going to take the extra steps or precautions. So when we look at, non-stigmatizing language, a lot has changed. I mean, really in just a few short years, of what to say and what not to say. And I know that, in a lot of ways, this is, something that is happening culturally and socially, but, we really want to recognize that we're talking to people, and I've always said to my clients, you are more than the worst thing that you've ever done, right? And so when we continue to just label people as an addict, as an abuser, as a junkie, that becomes their narrative. That becomes that defining, statement of who they are. And again, if somebody believes that they are a junkie, that sense of hope and that sense of ability to, be able to do things differently is significantly diminished, because that becomes, again, that primary definition of who they are. So, we no longer use, addict, abuser, user, dirty, junkie, drug habit, abuse, problem. We really want to kind of take a lot of that out of the narrative, and use person first language, a person who's currently or actively using substances, a person who's using drugs, a person with an opioid or a substance use disorder. And we really especially want to change the dialogue rather than saying substance abuse, which again, I mean, even for myself, 12 years in the field, I know that that is kind of how we have all referred to it, but really kind of challenging ourselves to take that word abuse out of it. And many folks found that it was really difficult for survivors of domestic and intimate partner violence, and it was really kind of muddying the waters of what this word really meant and putting a very different connotation to it. So we use use, or misuse. So substance use, substance misuse, somebody with a substance use disorder. They're using regularly or in an unhealthy or heavy way. So we really want to kind of change, a lot of those words, which again, it is difficult. I am still struggling with it at times, and I tried very hard to kind of catch myself. But, as hopefully this is kind of empowering many of you to be able to at least start the conversation with your clients, really being mindful of the words that you are using, and helping, for those individuals, those families, those people to feel like they are a person first. Much the same way that, we try to say, a person with schizophrenia instead of just calling them a schizophrenic, right? We want to try to challenge all of this to be able to, be a person first, a person who is, struggling with regular use or heavy use, or misuse of a medication. And again, keeping that person, centered in the conversation, in the discussion. So again, we're trying to, we want to avoid, using clean, former user, reformed addict, and instead a person in recovery, somebody who is abstinent, somebody who is not actively using, avoid relapse, and instead, resumed use or reoccurrence of symptoms. And that's really kind of following the disease model of, it's a recurrence. The symptoms came back, but somebody is continuing to manage it. And the same thing for a dirty or a clean drug screen. Again, a person is not dirty. A person is using. A person is, testing positive, right? So again, we want to really be mindful of how these words and how these conversations can negatively affect our clients, and certainly negatively affect their ability or desire to want to talk to anybody about what is going on. So similarly, instead of, it used to be medication assisted treatment. So now we, really looking to use medication for opioid use disorders. And the same thing for addicted babies, or a baby born addicted, babies born to substances during pregnancy. A baby is not an addict, right? A baby is, born physically dependent on a substance, and on medication, and, engaging with different providers to be able to work through that. So again, just keeping that in mind, and kind of in the back of your head as you're beginning to have these conversations. So for the sake of time, because it looks like we've got about 20 minutes left, and like I said, this was my first run through, so I guess I'm glad it's taking a little longer, but I do want to make sure that we get to, the kind of importance of having the conversation, and then specifically what an overdose is. So I'm not going to go through the activities. But we do want to look at the overdose rates, which, like I said, over 100,000 deaths in the United States. And in New York State in 2020, over 5,000 people died of an overdose, which is 15 people a day. The fatal overdose rates, again, here's homicide rates, firearms, and here's the overdose death rate. And it's just, I don't care how many times I see the slide, like it's just like such a stark difference every single time you see it. That this is a growing and ongoing problem, and something needs to change. So again, looking specifically at many of the individuals that y'all work with is, the pregnant parenting and postpartum persons. So in New York State in 2014, 55% of all pregnancy-associated deaths were the result of an intentional or non-intentional injury. And of those 55%, 36.4% died from substance overdose. And pregnancy-associated deaths are defined as a death within 1 year of the pregnancy, from a event not directly related to the pregnancy or birth or delivery. Journal of Women's Health in 2021 found that fatal and non-fatal overdose events decreased during the third trimester, but increased significantly from 7 to 12 months postpartum. So really looking at that time from birth until 1 year following delivery is one of the highest risks of time for a new parent. And again, Massachusetts Department of Public Health found a very similar trend in that opioid-related overdose 6 months to 1 year postpartum was at its highest risk. And really looking at, again, prescription and medication misuse. And I know that much what we've been talking about is related to folks who are using in a heavier fashion. But again, overdose is largely problematic for those who are using occasionally. And medication and prescription misuse is also a significant problem. And especially if we're looking at those who are postpartum, physical pain, emotional pain, being a new parent is hard, period, without any of the increased, risk factors, and, all of the other concerns that are in place. And then we're going to add in, potentially a large amount of prescription medication. And, folks know that it is in fact, an easy fix. And, again, I have yet to work with a single client who, set out with the intention, to use heavily, right? There was no intention, to meet criteria for a substance use diagnosis. It starts with that using occasionally for that quick fix and to, have that pain alleviated. So again, when we're looking at prescription medication misuse, it really increases the risk for those new parents, because for many, the medication is there. And then when it runs out, it does not take very long for that physical dependence to, to develop within the body. So nationally, 49% increase in overdose deaths between 2019 and 2021, and in New York State, a 50% increase in the same period of time. We do know that the pandemic, a large factor in that, but it's not the only factor. The increase in fentanyl, the increase in barriers to treatment, and the increase in presence of these substances for those who are not even necessarily meeting a substance use criteria. Again, for those who are using occasionally or socially, treatment isn't on the table because it's not necessarily, what the need is. Instead, it's about getting the information out and having these conversations and being able to comfortably discuss harm reduction. So 75% in 2020 of the deaths in New York involved fentanyl or its analogs. So overdose deaths in the United States, We are looking at the overall overdose rates, and then the synthetic opioids. So again, we're seeing a really large jump between 2020 and 2021. So very similar, and this one includes New York City. So I do want to make sure that we get to the naloxone component. So available to the public as a nasal spray. It's a stronger affinity for the opioid receptors than the prescription opioid, heroin, or fentanyl. So naloxone displaces opioids from the receptors and temporarily reverses or blocks their effects, therefore restoring the individual's ability to breathe. Administering naloxone can cause acute opioid withdrawal if the person has opioids in their body. But again, acute opioid withdrawal is not the same thing as an overdose. And while it is uncomfortable and not necessarily where an individual wants to be, they are alive if they're experiencing withdrawal. The overdose is what completely decreases and eventually stops the ability to breathe. We will do one more video. And then, so I think what we're going to do is I'm going to show this video, and then I would love to take a little period of time for some questions. And I want to be mindful of folks' times. So we'll watch this first, and then I'd love to just, like I said, have a little bit more room for any questions that folks might have, and we can kind of navigate from there. So, Jen and Maggie, if you could let me know if you can hear.
And this is where naloxone can help. Naloxone has a strong affinity to opioid receptors, more so than most prescription opioids and heroin. But unlike opioids, naloxone is an antagonist. This means it attaches to opioid receptors without activating them. So when naloxone is administered during an overdose, it knocks the opioids responsible out of the way and allows breathing to normalize. Naloxone can be administered through an injection or a nasal spray. It usually starts working within a few minutes and lasts from 30 to 90 minutes. While one dose of naloxone can reverse an overdose, sometimes multiple doses are needed, especially in cases involving extremely potent opioids like fentanyl or opioids that stay in the body longer than naloxone. Naloxone is very safe in single or multiple doses. It may produce withdrawal symptoms in people with opioid dependence, but it has no abuse potential and cannot cause an overdose. It's important to remember that naloxone is opioid specific. It has no effect on an overdose caused solely by non-opioid substances like benzodiazepines or alcohol. At the same time, people shouldn't be afraid to use naloxone when the cause of an overdose is unknown. If opioids were not involved in an overdose, it won't cause any harm. If opioids were involved, naloxone can save a life.
So I apologize. I'm not sure why the previous video showed that whole thing. So now you get to see it twice. Important to consider that the only purpose is to reverse the opioid overdose when using naloxone. It has no effect on the individual when opioids are not present, and that as regardless of age, if a child accesses naloxone, sprays it up their nose, nothing is going to happen. It is not harmful. It is only going to reverse an overdose. Again, there is no additional risk. It is possible to that both the overdose and the overdose reversal could cause physical stress to the pregnant person and increase one's risk of complications. However, the risks posed by oxygen deprivation or death from overdose outweigh the possible risk of fetal distress from overdose reversal. Without intervention with naloxone in an overdose, a pregnant person, both the pregnant person and the fetus will die. So there are several myths and misconceptions, which I will send the slide deck out to folks. And again, I'm happy to have further conversations. I do just want to make sure that we have some time for questions. And an important acronym for folks to remember is ANCHOR. So assess naloxone administration, call 911, have additional naloxone ready if administer is needed, observe and perform rescue breathing, and then review and monitor the individual's condition. And then the last thing to let folks know is the Good Samaritan Law, which protects everybody from it. It protects you in the event that the individual does not, survive the overdose. You are not liable if you administer naloxone and anything goes wrong. And then it also protects, again, the individual calling 911 regardless of age, and the person experiencing the overdose. So, if either the person calling or the person overdosing is in possession of a controlled substance, up to 8 ounces, sharing drugs, possession of marijuana, possession of paraphernalia, or the possession of alcohol for underage individuals. All of those factors are protected under the Good Samaritan Law, and that is done, as a way to, now. I did want to, like I said, kind of take a couple minutes to see if some folks have questions. Largely I appreciate everybody kind of, being my first round on this, because I realized that I could talk for far longer than an hour on all of this. I feel like I did not get through everything that I wanted, but it is at least a good place to start. Just trying to get my mouse to work so I can stop the screen share. And then I would love to hear from folks with any questions.
Thank you, Jess. We appreciate that this is your first time doing this. And thanks for hanging in with all the technical issues. I just took over from Maggie. She had to run. We do have a couple of questions though. So let me start with those. One came in, are you able to give fentanyl test strips to local health departments through this grant?
Very likely. And if I can't, I can at least, kind of connect you with some other options. So what I am going to do, I'm going to pop in the chat my email address, because it's under a grant, there are, and some restrictions and things like that. But luckily, because of the populations that we're really focusing on, I think we've got a lot of wiggle room. So I will put my email in, and so if whoever asked that could reach out to me, we can navigate the ability to be able to make that happen.
Thanks, Jess. Another question was, what does ANCHOR stand for?
ANCHOR is, hold on, let me go back. It is meant to assist folks in correctly administering the naloxone. So it stands for assess naloxone administration, call 911, have additional naloxone ready, observe and perform rescue breathing, and review and monitor the individual's condition. So with our overdose prevention kits that we are in the process of putting together and being able to kind of distribute to folks, we will also have a kind of palm card in there, which will be able to assist in remembering that acronym to, again, be able to kind of just help, increase that comfort of being able to administer naloxone. Because again, we know that when we all sit in on trainings, we feel really informed in that moment. And then if we don't use those tools and skills, kind of immediately, we can lose some of that confidence.
Okay. Thank you for that.
Absolutely.
We have a question from Jean Kramer. I don't know, Jean, if you want to get a little more specific. She asks, do you have a link for rescue breathing?
So there is one on the slide deck, which I will send out, and it just provides the kind of very basic concept of, rubbing the sternum, and then encourages, if you are trained in CPR, to administer that, but we don't provide the CPR within this training.
Thanks. Are there any other questions? Feel free to jump in if you have one. We've got a couple minutes. And we will make these slides and the recording available.
And I think the largest piece, kind of just for everybody here is, again, being able to increase everyone's comfort with speaking with your clients, speaking with your families, and just, finding out what is happening and offering this information. I'm a big believer that if we require folks to ask, they're not going to, and that in itself has been a missed opportunity. So, if we are able to provide the information, then somebody is just receiving it. They're not having to, really face that initial barrier of having to ask. And so what we are doing, and again, thank you all for being kind of my, I guess, guinea pigs, for lack of a better term, and kind of navigating this a bit. But what we are going to be able to do is, train health departments, home visiting agencies, child welfare agencies, as a whole. And then we can navigate getting and shipping our overdose prevention kits to the agency themselves. And on those kits will be a QR code, which actually will go directly to our webpage, which has a 5-minute training video, really on what an overdose looks like and how to administer the naloxone. And that's really geared specifically towards those highest at risk of, experiencing or witnessing an overdose. So again, I'm not, putting on anybody to be overdose prevention trainers, to be substance use providers, but instead to be able to have that very basic conversation, with your clients, offer them that kit, and then they can go on and watch the video themselves. And again, then we're getting the information out there, and we're taking some of that fear and judgment away if we just, again, approach this in a very universal way.
Any other questions? And Jess, I apologize because I got on a little late, but are you available if someone on this webinar reaches out and wants you to do a training for their home visiting program or what have you, you could do that?
We are, getting all of the kind of final kinks worked out of this, but please, again, I put my email in the chat, and I'm also going to be sending out, with the evaluation and after this with the slide deck. But please, would love to start scheduling trainings for any of your agencies. And again, then navigating getting the kits sent over, which would potentially include the fentanyl test strips as well, and also doTERRA bags, which we didn't even get a chance to discuss, but that's the safe medication disposal pouches. So it's a charcoal-based bag in which prescription medications can go into the bag. You mix a small amount of water in, and it completely deactivates the medication. So that, once it's thrown in the garbage, even if a pet or a small child were to access that bag and get into it, they're no longer at risk because, again, it's completely deactivated. So those are all of the things that we're kind of incorporating within this. And I see a question about who is eligible for the kits. So specifically through our grant, it really is anyone. Luckily, we've got, again, kind of some nice wiggle room. Anyone who really works directly with pregnant parenting, postpartum persons, survivors of domestic or intimate partner violence, members of the LGBTQ+ community, and tribal communities. So if, your agency feels like, it in any capacity, meets some of those, some of the needs of that group, please reach out to me, and I would love to start getting training scheduled again, beginning in August. We can cross our fingers and hope that some might even be able to be in person, but we'll also be doing the virtual, and I promise I will be better versed in it by then. So, but part of that will also include the idea of kind of how to have the conversation with clients, knowing that there is that kind of fear in having a conversation that, we may not necessarily feel comfortable with.
Thanks again, Jess. I think you did a great job. If we need to do a part 2 on this, we're happy to host that for the HVCI. Okay. So we should talk offline.
Yeah, that sounds great.
Okay. We will, Maggie will be sending out either later today or tomorrow the slides, the link to the recording, Jessica's email address, which is also in the chat. And then there will be a really short evaluation. If you could please fill that out for our federal partners who pay for this wonderful series of webinars. We'd really appreciate that. So thanks for your interest. I think this is, it's obviously a hot topic and something that we want here at Prevent Child Abuse New York, information to get out to as many people as possible so that we can, better strengthen our families and better protect our kids. So thank you so much.
Thank you.
Bye, everyone.
Encourage folks to call 911 because for a long time, it was as soon as somebody overdosed, folks were running away because they didn't want to put themselves in jeopardy.